Good morning, Sarah.
Good morning, Jeffrey. How are you?
Excellent, excellent.
Good.
So where are you? It looks like you're at home, are you?
I'm usually in Adelaide. I'm actually in Sydney at the moment, staying with a friend on TRD or an externship. So I'm in Sydney at the moment, but usually in Adelaide.
Right. Okay. Yeah, I worked in Adelaide at AAERC for what, about a year and a half at one stage.
Okay. Good. I don't think AAERC exists as of this week. They've merged into it. They had to build a highway where that building is. So they have merged into another practice, but that's only happened this week.
Oh, right. Yeah,
Hmm.
it was on two busy
Is
roads,
interesting.
basically.
Yeah. That was an interesting development. Yeah, I think they reopen next week, but in a different spot.
Oh, okay. Yeah, I had a flat at Glenelg North.
Oh, that's lovely.
Yes, it was nice. I used to cycle to work
Oh, that would be
each
nice.
day,
Yeah.
and along mostly on parkland, and Adelaide's really good for that.
Mm, mm.
It's a great lifestyle.
Yeah, it's a good spot. I'm
Yeah.
getting used to the traffic in Sydney. It's
Oh,
a bit scary.
no one gets used to that.
All
After
right, not just me then.
working 8 years recently in good morning, Anna.
Morning. How you
Good
going?
morning.
Morning.
Just having a whinge about Sydney's traffic.
Oh yeah. Stay home, Jeff. Work from home. It's definitely you hear about so many other industries being able to work from home and stuff. It's like I really want that.
Yeah, well, remember we're a profession.
Beg your pardon. Not an industry.
That's right.
Is animal care an industry?
Yes.
Okay.
Yeah, we work in an industry perhaps, but we are a profession.
Yeah, okay. And is the veterinary profession, does that only include vets, or is it everybody employed within the veterinary profession?
Well, it doesn't include nurses.
Okay, right. So if
You'd
I
have
say vet industry, and I mean everyone that's employed in the veterinary
that surrounds the veterinary profession.
Yeah.
Yes,
Would
I
that be
agree.
correct? Yeah. Yeah, nurses can't work from home very well either.
Yeah. Yes, but casual work's getting harder to get.
Oh, yeah.
Yeah, I've just had a good 3 months run with Green Cross, but they put on some permanents, so they're cheaper than and I mean 2 permanents is 10 shifts a week. I'm only 2 or 3 when I'm working and not gallivanting around the world or kayaking on the
Yes.
Lake Macquarie or skiing or whatever.
Yeah.
It's a hard life.
It's such a hard life. It's one event though.
Well, yeah, yes.
Not negotiable. Yeah.
Yeah.
Good. Okay, so this morning we're talking about echo and ECGs. I love this topic, but I actually realized I was talking to Helen down here yesterday, and I said, "Oh, I wonder what the tutorial's on tomorrow." And Helen was like, "It's on echo and ECGs," but then I didn't actually check that, and then I prepared for it, and I was like, "Oh, it better be on echo and ECGs," and it is so simply.
Yeah, well, I'd forgotten about it until I have it on my calendar as a recurring event, and I've got reminders at 7 to wake me up and at 10 to 8 to get onto the computer.
Yeah.
So,
roll out of bed, Jeff.
Yeah, so I got
wake up, Jeff. That's fun.
Picked up.
Anyone with kids will understand that joke. It's a Wiggles joke. Okay, so I wasn't sure where to pitch this because there's probably people who've done like quite advanced echo, and then also people who are studying memberships and never seen an echo. So I have kept it pretty simple as far as echo section, but I will just throw it out. Is anybody doing echoes?
No.
No? Okay. Trying.
I'm trying. It's
Yeah.
really
It's really hard. It is. Just do as many as you can.
Mm.
And Helen's definitely doing echoes because I make her do them every day.
trying.
Yeah. We had a week last week, and I think Helen had like 3 echoes in a row or something like that, and she wasn't well. And we got to the end of the day, and she's all sunny. I said, "How do you feel about today? You're doing really well." And she goes, "It was the worst day of my professional life." A huge smile on her face.
Yeah.
They're really hard.
It's really hard. But I think the important thing is that, like, with 2 views, pretty much, like 2 angles, you can get all the information you need for 99% of patients. And I think what's hard for us perfectionists is that you don't know what you're missing when you can't do the full thing, kind of thing. But you've also got a really strong medical background, and you can then sort of say, okay, well, I'm not sure, I can't see any mitral regurg, but there's volume overload here. What other mechanisms might be causing that? And you can kind of work backwards from there and then say, well, I've ruled out this, and now I need like tertiary referral to blah or whatever. So I think don't not do an echo just because you don't know how to spot a PDA, because in 99% of patients, the standard of echo that you're able to do is going to be sufficient for your patient to provide accurate treatment recommendations. So would anybody want to cover anything specific? Not really? Because it's obviously like talking about echo when you're not doing it, like the whole thing is like muscle memory of the movement and stuff and how to position the probe and stuff. So what we'll talk about is more like the diseases around the echoes, like what you can see in the different views, and then how you might kind of respond to that. If that's all right with everybody.
Yeah, sounds good.
Okay, let's go here. Oh, a really good resource if you're just starting echoes or sort of looking to just like if it seems really intimidating, this is a really good paper. So it's like in general practice, but as I said, that's 99% of the patients that you're seeing are the mitral valve dogs. So echocardiography in general practice, 4 views to master. And that's what I've sort of based the views that we'll talk about today on. And it's in Clinician's Brief. It's a really easy read, really good diagrams and stuff like that. And I've used a few of them in here, so I just wanted to reference it. So the first thing we're going to do is picture our dog on a lateral x-ray and where the heart sits in the chest. Can everyone picture it?
Yeah.
So it's on, I'm going to try and do this reverse so that it's right for you, but base of the heart up here and apex of the heart down here. Yeah, good. Excellent. So now looking at the view on the screen, which is reversed, but we're going to picture that heart sitting in the chest, and where you're going to put your probe is going to be right on the side of the heart, but just slightly towards the apex. How are you going to know that from the outside when you're not looking at a like fluoro to guide where to put your probe?
I mean, I usually feel the heartbeat as a starting point.
Yeah. So the point of maximal intensity, that apex beat that you can feel, where you can feel the heart the strongest, that's where the heart's sitting against the chest wall. And that's going to be your window. So first view I always do is this long axis 4-chamber view. It is the most important view. We don't actually get very many measurements that we then have reference ranges and interpret kind of with regards to like ratios or anything like that from this view. But you will get the biggest, as a medicine brain, you will get the biggest impression of what's going on in this heart from this view. So we've got our patient in right lateral. We've felt for where the heart is touching the chest underneath it. And then we're going to put our probe on the heart, thinking about the angle of the heart sitting in the chest. So if you've got your light pointing directly towards the head, you're not going to be getting the heart in its long axis. So you want to angle it almost like 11 o'clock. So if the spine is 12, you're just off from there. So like just cranial, your light is just cranial to that. Does that make sense? I used to have a heart model. I shouldn't say I used to have, my old business used to have a heart model. And
I'd love one. Can I get, where do you get them from?
Well, they're on, like, I just had a look actually online because it was so helpful to try and comprehend this. Like, you look at a heart whole and then you look at it in half and you're like, well, they don't correlate at all. But it was very helpful to teach it. But I then left that business and I haven't replaced my heart model, and it would be a weird decoration in my home office. So one day I will get one, and they're like $300.
Oh,
Yeah,
that was
it's pretty niche. If anyone wants to go into business making heart models.
You could probably get one 3D printed from someone.
Oh,
My partner has a 3D printer. All right, I'll get onto it. I'll let you
Yeah,
know.
try
I
it.
love that idea.
Because they're actually going to use them to make bioprinting actual heart replacement hearts in the future.
Well, I want one that splits into 2 pieces, please.
All right, I'll see what I can do.
Amazing. Thank you. Okay, so I've just put a little video in here of the 4-chamber view. What are we seeing here? Tell me all about it.
About
Right in the middle is the mitral valves.
Yes, yeah.
Yep.
Good. What do you think of these mitral valves?
are they thickened?
I think they look okay.
Yeah. If we look here, you get the impression there's a bit of a clubby sort of thickening right on the tip of the mitral valve. But other than that, these valves are pretty good. So if we look at peak systole here, so ventricles contracting, mitral valves are closed. They're not actually prolapsing into the left atrium. So when you get degeneration of the mitral valve, they start getting weak and they start going like that as the ventricle contracts. So there's not a lot of sort of degenerative change in these valves. What else can we see on this view?
You can get an impression of your left and right atrial size. So your left atria being at the bottom right-hand side screen, and you can get an impression if it's really volume overloaded, like if it's even bigger in the ventricle, for example, and same with your little right.
Yeah, completely agree. So on this view, you can sort of say, okay,
Atria above it, close to that screen.
beg your pardon? Oh, I missed that. Sorry, Helen. We always cut off the right atrium a little bit just because of the angle of the wedge that the probe makes. And you can sort of angle a little bit to maximize that. But particularly in cats, I really like this view because their atria should be pretty symmetrical. Like dogs often have like a slightly bigger left atrium to right atrium. And you just get this impression like, oh, that left atrium big, or that right atrium's big, or there's an asymmetry here, and get a bit of an impression of atrial size. It's obviously not very scientific, but medicine brains getting impressions from everything. What else are we looking at?
I'm not particularly impressed with the contractility of the ventricles in that case.
So good systolic function. So contractility, how much is the heart dilating and how much is the heart contracting, and what's the difference between that dilation and contraction? What do you think about the heart rate in this dog?
Pretty slow,
Yeah, it's pretty slow.
which makes for an easier echo in my personal experience.
Oh, so much easier. Do you know humans? So I've got a friend who's an emergency consultant, and he did like this master's in echo, and he's like looking at some videos of cats and saying, oh, you need to drop their heart rate to 80 to be able to interpret that accurately. And I was like,
Okay, we can kill them.
you're funny. Well, let's kill the cat. It's a good idea. It's also got a liter of pleural effusion in its thorax. Anyway, so humans, they drop the heart rate has to be under 80 for them to do an echo, otherwise they won't touch it. So they give beta blockers until they get a heart rate under 80, and then they can do it, an echo. And this is in an emergency setting as well. It's quite amazing. So I'm sure they do it, like, you know, if in patients in congestive failure, I'm sure they wouldn't do that. But anyway, interesting conversation. So the heart rate's nice and low. What does that tell us about this heart function?
It's probably good.
Not in stress.
Yeah, exactly. Yeah. So this is patient who has a sinus arrhythmia, we sort of saw that kind of speed up and slow down. The first response to decreased cardiac output is increased sympathetic nervous system stimulation. So you lose the sinus arrhythmia and your heart rate just gets progressively higher as your cardiac output drops. So if you've got 90% of your cardiac output, 90% of your ventricular volume going out your aorta, and then 10% starts going back through your mitral valve, you're going to get a drop in output, and your sympathetic nervous system is going to kick in and increase your heart rate to compensate for that. Make sense? So that's the first neuroendocrine, you know what I mean, response to onset of a decreased cardiac output. So I think whilst the contractility doesn't look amazing, it's doing enough that we're not triggering that sympathetic nervous system response. So it's probably that the dog's just quite relaxed and it's got a whole heap in reserve for if it gets stressed. And then its cardiac output and contractility will increase in response to catecholamines and things. So we've assessed atrial size, we've assessed the kind of integrity of the valve, size of the valves, whether they're prolapsing, whether they're thickened. And we've also assessed how subjectively what our contractility is doing. So they're the main things that I want to get out of it. And as I said, there's actually not very many formal views with reference ranges that we get in this view, but the ones that we do take are a left atrium in long axis. There are reference ranges for this, but it's actually very variable, and there's a lot of kind of inaccuracies in, even if I did 3 measurements like this, I'd probably get quite different measurements. So it's not one that we use routinely. What I like about it is that I can then compare this measurement to the one that I got in my LAAO. And it's just almost like okay, yeah, that makes sense. Like they're similar. Long axis is always a bit bigger, almost always a bit bigger than short axis. But if I can say, well, it looked really big on the left, on the long axis, and it only looks like borderline on the LAAO, then I'll go and do my LAAO again. Make sense? Next view I like to get, and next measurement I like to get from this view. Oh no, I put the wrong one in. Have I don't know. So what I've done here, I've got my long axis view, and then I've got my line just going straight across the ventricle, right behind the mitral valve. So this is mitral valve here. And what I'm measuring is the diameter of this left ventricle during diastole. So does anyone know the name of this function where it kind of gives you like a short axis cross section?
M mode.
M mode, good.
Mode.
So if I was to try and measure this on a live image, so when you freeze it and you go, yeah, I think that's diastole, and then, yeah, I think that's systole kind of thing, the frame speed is going to be like, you're going to miss those maximal points and smallest points. Does that make sense? So if I'm like going, oh yeah, that looks like diastole, that's the biggest one I've got, it might have gone like that in like a microsecond after, and the frame might have missed that maximal point. So M mode allows you to really see where is this ventricle at its absolute widest, and it's going to be across here. So again, this is not a measurement that we've got really good reference intervals for, but it's one that when I do my cross-sectional M mode view, I can say, oh, I think I've actually had the ventricle on an oblique angle or measured too far back, because you can really see where you are in the ventricle on this long axis view. Like I know I'm right behind the mitral valve because I can see the mitral valve. Make sense? So it's again a little just sanity check while you're learning echoes. It's really nice to be able to say, actually, those measurements are pretty similar. I must have been on the right spot. The next measurement I get from this long axis view is called EPSS. Does anyone know what that stands for?
Mitral endpoint septal separation. So how far the mitral valve, when he flings open, how far does he come back and touch the septum when the valves are opening? If you imagine like they open up and the one valve will go towards the free wall and one valve will go towards the septum, you're catching the valve that swings towards the septum.
Perfect. Say you had a patient with really profound volume overload and the left ventricle was absolutely massive, what do you think is going to happen to this measurement that is measuring how close the valve can get to the wall?
It's going to
Probably stop.
increase because the valve's not going to get very close to the wall.
Exactly. Yeah, exactly right. So the EPSS is a really nice indicator of DCM. And that's pretty much the only time we see it profoundly increased. Over 8 is DCM diagnosis, over 8 millimeters. And if you think about 8 millimeters in a dog heart, like dog heart should only be this big. If that valve is not getting within 8 millimeters of the wall, there's a really big problem. So it's got to be pretty bad DCM before it gets to that point, but it is a nice kind of marker. If you're sort of thinking that contractility doesn't look great on your initial view, just get your EPSS. And if it's under 8, or in fact, most dogs, it's like 0 that the valve touches. It gives you a bit of an indication of what you should be looking for and what measurements you're going to want to get. Okay, so the next view, so spine is 12 o'clock. We started at about 11 o'clock with our light pointing at around about 11 o'clock. And then our next view is called a 5-chamber view, right parasternal long axis still. But the 5th chamber we're looking at is actually the aortic outflow tract and aorta. So we've then not maximized our left atrium. We're kind of cutting that across that. So it looks pretty little on this one. But in this view, you can still see the mitral valve and you can see the aortic valve at the same time. In a cat, what might we look for in this view that only really happens in cats?
Like a clot in the, is this the view where you look for a
Well, we'll probably see it more when we've got our left atrium maximized.
Okay.
If there's a clot in the left atrium, but a clot is usually like hiding in a wall or an auricle. So it's often like you do have to look at it on quite an oblique angle and make sure you're fanning through the left atrium to see it. But clot's not what I was thinking of.
Systolic anterior motion of your mitral valve. So your septal leaflet in cats of your mitral valve can get sucked into your outflow tract during systole. So hence the term systolic anterior motion, because it's going out your outflow tract of your mitral valve, and that can result in a dynamic obstruction like humans get in cats.
Do humans get it too?
Yeah.
I guess that's why it's called anterior motion, because we don't really use that word.
Oh, apparently it's really painful in humans, which makes me sad because we can't recognize that in cats.
That's interesting.
They probably just sit there quietly, hey, and have their Sammy.
With a liter of fluid in their chest.
Yeah, exactly.
That's exactly right. So systolic anterior motion. If you can imagine a ventricle during systole, is the mitral valve open or closed?
Open.
Closed.
Closed. Yeah, systole. You know this. So the ventricle's contracting, the mitral valve slams shut, and all of the blood is whooshing out of this left ventricle into the aorta. So this is a picture in diastole. So blood flowing from left atrium into left ventricle. If we picture systole, the blood's whooshing out through the aortic valve's wide open, and the ventricle's decreasing in size like this. And what sometimes happens at the end of systole, particularly with cats with hypertrophic cardiomyopathy, is that the blood is whooshing through a narrower opening, because all of this muscle is bulging, it's narrowed down this left ventricular outflow tract. And then we get this increased resistance flow, and that actually sucks this leaflet of the mitral valve open and into the outflow tract because of the altered like pressure dynamics there. Can you sort of picture it? Like if you had like a leaf just sitting on the side of a stream sort of thing, and the stream was very like slow flowing and regular, then it's not going to get knocked out. But if you increase the resistance to flow and all the water's moving a lot faster, that leaf is going to get flipped open or flipped out into the stream. So that's the way I picture systolic anterior motion. What about what other diseases in a dog might we be looking for in this view?
Aortic stenosis.
Yeah, perfect. Or aortic regurgitation, like diseases of the outflow tract and aortic valve. So this is the view where we'd really be able to visualize a subaortic stenotic ring or bulge. So you can see this left ventricular outflow tract sort of wide open like this. And if you had a little bulge here or narrowing, you could really see that in this view. And then the other thing you get quite often with aortic stenosis is the aortic valve itself is being traumatized by increased velocity of flow and turbulence of flow. So the valve itself often looks a bit thickened and bright and abnormal, which you can see on this view. There's not that many measurements we actually do from this view, but it's that sort of impression like, oh, when I'm suspicious of this, what do I need to do now to look for that disease? Oops, that one backwards. So from that, we've gone 11 o'clock. That 5-chamber view was at 10 o'clock. So we kind of just went spine's 12, 11 o'clock is like long axis, 10 o'clock is 5-chamber. Now we're going to come right around to about 8 o'clock. So we've gone from 90 degrees from where we started. So our light was pointing at 11 o'clock. Now it's pointing at 8 o'clock. So we're now looking at the heart. If we picture it in the chest, we're looking straight through the middle of it in cross section rather than in long axis. Does that, is that comprehensible? Sort of. So if you're looking at the heart through this bottom wedge, you're just going to be looking through the tip of the apex, right? So what's going to be in your view? What chambers will you be able to see?
Just the left ventricle, probably.
Yeah.
A little bit of that one.
Yeah, you might get a little sliver of right down the bottom. And then what about this top one? What chambers will you see up here? The ones at the top.
Will you see the atria in that place? Yeah.
Yeah, for sure. So this is probably left auricle here in the picture. So you'll be looking straight through the left atrium, straight through the root of the aorta, and then you'll probably actually see the pulmonic valve coming around. So this is kind of your LAAO view. The reason I wanted to like make sure that everyone kind of really comprehended that. So when you're doing a short axis view, you sort of fan right through from the tip of the apex right up to the base of the heart. So you get a lot of information on your way through, just as far as like getting a bit of an impression. But there's 2 points in that fan that we pause and do some really, really important measurements. So looking at this one, we're looking through the ventricle. So we're looking at one of these bottom ones. And this is a pretty normal looking cross-sectional view of the ventricles. The left ventricle maintains a round shape because it's got more pressure in it. And then the right ventricle, which is a low pressure chamber, just kind of wraps around it. So we've got left ventricle here in the round circle, the wall is round, and then right ventricle just wrapping over the top. What are these?
Papillary muscles.
Yeah, good. Yeah, so it's not quite round in the middle. And these really get in the way, actually, when you're trying to do your measurements. They're very annoying. So really good to try and avoid them and try and kind of manipulate your view so that you can get a line through the middle of them. And definitely recognize them because they are, particularly in cats with HCM, cat echoes are really tricky. They do make it very hard. This is a really low resolution image, but can you guys see that left ventricle, that nice mushroom view there? A nice circle. And this sonographer, they always put these pictures in the textbooks where the papillary muscles are perfectly like symmetrical and they sit
impossible.
there. It's impossible. I don't know how they do it. What animal is that? It must be the human view.
It's impossible.
I completely agree. Thank you. I'm sure cardiologists can do it and they're probably like when they watch this, but don't like if you're starting out with echo, like don't try and manipulate your image to make it look perfectly vertical. You just move your line over. So usually the papillary muscles for me sit at like 6 o'clock and 8 o'clock or 6 o'clock and 9 o'clock. So I just move my line so that it's going through the ventricle, through between the ciliary muscles. It's really important that you've got your line going through the widest point of the ventricle. So if your ventricle looks like that, you've still got to go straight through the middle. You can't go oblique. Does that make sense? Because otherwise you'll underestimate the internal diameter of the ventricle. So what diseases are we looking for with this view? Or what measurements will we be really paying attention to? If, for example, we saw a narrowing in our 5-chamber view in the aortic outflow tract and a bunch of turbulence and stuff there when we put colour flow on there, which measurement am I going to be most interested in as far as making a diagnosis here? It's a dog.
The left ventricle is going to be working harder. I'm just trying to think what it's going to do to it.
Good.
I suppose you
Over
get
time.
hypertrophy.
Yes. Good. Yep. Absolutely. So if you did your 5-chamber view and you were like, oh, that aortic outflow tract doesn't look right, the aortic valve looks a bit annoyed, there's a bit of turbulence, a bit of regurg through there, and then you went into your cross-sectional view and your IVSD and LVDD, so interventricular septum and free wall in diastole, were thickened, you can almost say that that dog's got aortic stenosis. So a muscle that has to work against increased resistance or a muscle that has to work harder is going to hypertrophy. So that's a nice kind of like medicine brain, like, oh, I'm putting the pieces together even without having an increased aortic velocity, flow velocity. So if you're using like an abdo probe, you can still get all of this information and have a really strong inkling that maybe this dog needs referral for interventional stuff or if you don't have Doppler, for example. What about in a cat with HCM? What measurements are going to be abnormal?
I mean, the same ones, like the ventricular measurements.
And why do I say during diastole rather than during systole?
When it's relaxed, you're going to get a better view of the actual size of it, I think. Whereas in systole, they probably all contract and look similar.
Yeah, I don't know if it's, I think there's more variability. So if you've got a dog that's really impacted by catecholamines or a cat, and their contractility's gone up under the effect of adrenaline and their heart rate's 220 and they're going from a really full heart to a really empty heart, that thickness of the wall when it's really empty is going to be thicker than quite a relaxed cat who's had some sedation. So I think there's just more variability with the systolic measurement than there is with the diastolic measurement. Having said that, there's still variability with those diastolic measurements. So if you've got a patient that's heart rate's really low, their heart's going to fill more, isn't it? Between beats. So their internal diameter and it's going to be bigger and their walls are going to be thinner. But that's less variable than the systolic changes. What about in a dog with DCM? What measurement is going to be the one that I'm suspicious from my 4-chamber that contractility is not great?
When you work out or when the machine works out your fractional shortening.
Good, excellent. What's fractional shortening?
I suppose it's the percentage change in left ventricular diameter or something between systole and diastole.
Yep. So it's really nice because the machines calculate it for you, but you don't need a fancy cardiac package to be able to do a fractional shortening. Fractional shortening is the diameter in diastole. So when the heart is as full as it gets. So if we run along here and go, okay, when is the heart as full as it gets? It's like across here. So that's our left ventricular internal diameter in diastole. And then it's that measurement minus the systolic measurement. So full as it gets and as empty as it gets. So we've worked out now the difference between diastole and systole. And then you divide it again by the diastolic measurement. and it gives you a percentage. So what percent is that ventricle changing in size? So what would be normal?
25 to 45 is normal, is it?
Yeah, good. So if you're getting under 25, you're probably dealing with DCM. Every now and again, I do echoes in really relaxed dogs or really sedated dogs, and their heart rate's like 50, 60, like they're really chilled out. And their fractional shortening might be like 23 to 25 kind of thing, because they've got a lot of reserve. But if their heart rate's low, they don't have DCM. So there's always dogs that sit just outside the bell curve, and cats, their fractional shortenings can be quite high when they get catecholamine affected and their systolic function increases. So when we talk about systolic function, these are the measurements of systolic function. When you get dysfunction of systole, so DCM is the main one that we see, fractional shortening reduces, and the difference between diastole and systole is smaller. Is there anything else I should cover from this view? Because we get so much information from this one. Oh, yes, there is. What about mitral valve disease? I'm talking about all the zebras. What happens when we transition from a stage B1 to B2 mitral valve disease?
The LA-AO ratio changes.
And there's two criteria. Right. Can you hear what's going on behind in the background? Okay, good. The other criteria, so left atrial enlargement is one of them. The other criteria is actually increasing this LVIDD. And it's not even increasing above normal range. It's just sitting in the top end of the range or higher is the criteria for starting pimobendan. So why would LVIDD go up in a dog with mitral valve disease? What's after the sympathetic nervous system kicks in and they lose their sinus arrhythmia, what's the next kind of neurohormonal mechanism of compensatory mechanism that is quite detrimental in heart failure?
Ventricle is going to dilate to contract more strongly.
True, that's kind of the sympathetic nervous system though.
Like
So-
activation of RAS.
Yes.
Sodium retention, yeah.
Yes. And then, did you say fluid retention? Exactly right. Yeah. So we usually get sympathetic nervous system activation, then activation of RAS causes fluid retention. And how is that going to impact the volume in the heart?
It's like volume overload.
Yeah, exactly. So that's the second criteria for recommending pimobendan is you've got to do fancy calculations, but Vin will do that for you. Vin's got a really good echo calculator if nobody's found it yet. And you just plug your values in and it normalizes them through the formulas for you. Yeah. And if you get an LVIDD normalized value over 1.7 and a left atrial enlargement, then they're B2. Okay, so we still have our probe at 8 o'clock-ish, but we're looking through the ventricle. So we were down here, just under the mitral valve. And as we're going to fan our probe up, so remember a terminology we spoke about in our POCUS one, we're fanning. We're going to go ventricle, we're going to go mitral valve, we're going to see that flipping in and out of our image. And then just above that, we're going to fall into the left atrium. And hopefully the aortic valve in perfect cross-section where you can see all of the detail of the valves looking like a Mercedes sign, which for the record never happens. So you'll see these beautiful images in textbooks. And you might see one of the valves and you can see that the aorta is a perfect circle and you're like, okay, well, I'm definitely on the right view, but it's never quite as clean as this. So we're looking at left atrium here, aorta in cross-section, and then the right ventricular outflow tract, pulmonic valve, oopsies, and then pulmonary artery down here. So this is a view we can get quite a lot of information from as well. What diseases are we screening for with this view?
I mean, we can look at the size of the left atrium.
Yeah, perfect. So anything that results in volume overload and left atriomegaly. In a dog, what would be the most common cause of left atriomegaly?
Mitral valve disease.
Mitral valve insufficiency.
By far, this is 99% of the patients that you'll see. What diseases might you see where there's profound left atriomegaly but only a soft murmur in a dog? Also associated with like profound volume overload. So if you, we've already talked about it. It's not a common disease in dogs, but you'll get a reduction in systolic function and fractional shortening.
HD.
Yeah. Sorry.
Hypertrophic cardiomyopathy.
No, it's actually DCM. So there's two kind of, the reason I highlight this is because left atriomegaly, we typically think of it as blood coming back through the mitral valve, causing volume overload in the left atrium. So what's actually happening in DCM is the ventricle's so full and it's so volume overloaded and nothing's going out of it. So the left atrium pressure just kind of backs up and backs up and backs up. And often you barely hear a murmur and they've got profound volume overload and left atriomegaly, but there's actually not a lot of mitral regurg. And you don't actually get a mitral regurg until the heart gets so volume overloaded that the mitral valve can't even meet anymore. It just pulls them apart. So the left atriomegaly is often so profound that we often see arrhythmias with DCM, more often with DCM dogs than we do with mitral valve dogs. And if you ever sort of hear a murmur, like see a heart on an X-ray and go, that is enormous, that doesn't fit with this grade of murmur, I'd be quite suspicious and just do that fractional shortening as a screening test if you can't do a full echo. So LAAO measurement. Oh, sorry,
just a question on the fractional shortening. In that M mode where you had like the green and the red the lines, you have to do those measurements yourself, and then it'll calculate you have to choose where the thickest and thinnest parts are, and then once you plug those two lines in, it will calculate FS off that.
Yeah, exactly right. Yeah. Or you can calculate it yourself if you've got those measurements and don't have a cardiac package that's doing it for you.
Yeah.
So the other thing that we're going to screen for in this view is pulmonic stenosis. So you can really nicely see the right ventricular outflow tract. You usually be able to see a narrowing here, and you'll definitely be able to see turbulence. And the other thing that we sometimes see is actually when there's a stenosis and the blood's coming through in a really narrow jet, is you actually get a post-stenotic bulge in the diameter of the pulmonic artery and aortic as well for both of those. So there's a couple of hints, even if you don't have the capacity to measure velocity, that you might be dealing with a stenosis. We measure velocity across this valve from this view, and we do a measurement in the pulmonary artery and we do a measurement in the right ventricular outflow tract. Why would we want to do two measurements in two different locations? If we're talking about pulmonic stenosis, how might they be different? The velocity of flow here before the stenosis and the velocity.
Well, if there's stenosis, they're going to be very different.
Yeah, exactly. Yeah. So higher after the stenosis or lower?
Lower. Oh, yes.
Your 50-50s today are out. I know you know this. So you've got a stream. It's a really wide stream. And then all of a sudden that same amount of water needs to get narrower. And it has to move faster. To get the same volume through a narrow opening, it has to move faster. So after the stenosis is going to be faster. So the pressure differential from here to here is going to be quite high. All right, so we talked about LAAO quite a lot with the POCUS. You will notice, or you may not notice, standard cardiac views are reversed. Your light's on the other side, or your marker's on the other side. So if you're doing an abdo ultrasound, your light's over here, your marker's over here. If you're doing an echo, everything's reversed. I don't know why they do it that way, it just is. Yeah. So when you're doing a POCUS with your abdo probe, with your abdo settings, your image is reversed. And it blows my mind because I'm so used to looking at it this way that people ask me if this left atrium is enlarged. I'm like, I'm pretty sure that's the pulmonary artery, but I don't know what's going on. Anyway, this is the way that the cardiologists do it and what most of the textbooks will show you. Mm-hmm. We've got aorta in cross section, and you can kind of see the scallops where the valve attachments are. Can you see that? Looks like a bit like a clover. Mm-hmm. But you can't really see the valves very nicely. You get the impression there's like, yeah, one there, and then one going straight down here where those scallops are attaching. So you want to make your line go straight across and through where those leaflets join up on the point that joins the left atrium. And then you want your left atrial measurement to go straight across, completely parallel with that to get a standardized measurement. Whoopsies. A trap here is you can kind of see that we're getting a little bit of like a black hole down here. When you've got an overloaded left atrium, the pulmonary veins also get overloaded and they enter the left atrium right there. So when you're doing your line, like the textbook says, you could legitimately measure right down to here until you hit a wall. But what we often have to do is just imagine that the wall's going across here and draw a bit of an imaginary line and measure to that point. So this is where the LAAO is a very variable measurement. And if you do it 4 times in the same patient, ideally you want to get those measurements within 10%, but I've been doing echoes for so many years and mine still vary quite a lot, which is why I always do that long axis left atrial measurement. Just make sure, did I think the left atrium looked overloaded when I was looking at the 4-chamber view? Like, does this measurement make sense? Or have I accidentally measured right up into a pulmonary vein and the left atrium is actually normal in size or something? So always just check yourself, because it's not it makes it sound so formulaic and guaranteed in the textbooks, but particularly those borderline cases where you're working out pimabendan or no, you want to be as accurate as possible in checking yourself. It's pretty obvious when they're in congestive failure because it's like the size of Texas. But... Okay, we can cover ECG in 10 minutes, right? It's not very complicated. Was there any questions about echo? Does anyone want to cover anything else? So I've gone through, this is obviously not a complete echo. There's a lot of velocities and things like that that you can do as well. And I'm like very happy to send around our standard like list of views that we do. In fact, there is an echo tutorial that we did internally for our team, which covers the views that we do as standard. So if anyone's interested in a more advanced version of this, you can go onto our YouTube channel and find that. Cool. So that's probably a good like starting point. And that goes into like, you know, aortic stenosis, pulmonary stenosis, what do we see in CAT SAM and stuff like that in a little bit more detail, a lot more detail with a lot more views. We take a lot of views. So the idea of our echoes are that anybody can do that echo and anybody can interpret that echo because they've got all of the information they need. So a lot of patients that we're seeing don't need 90% of the views, but just in case I've missed something, like I'm a medicine specialist, not a cardiologist, there are cases that I see, I'm like, I have no idea what's going on here. This needs to go to a cardiologist. And I can send all my videos and views for them to review and they can go, oh, you idiot. This is what it is. So yeah, have a look at that tutorial. It's pretty detailed, but if you want more. Okay.
And I have a quick thing. Could we cover quick? So I'm so sorry if you've already covered this. I was just away from the meeting, but the LAAO changes so much in the cardiac cycle. Could you just touch on when exactly we should get that freeze?
Oh, yes, that's a really good point. Yeah, exactly.
Thank you.
I think I can tell you that. So you want the aortic valves to be closed. You want to be able to see those joins in the valve. So where is that in the cardiac cycle?
In diastole?
Yeah, exactly. Yeah. So pretty much as soon as those aortic valves close, you want to get your measurement. So right at the beginning of diastole. Does that answer your question?
Yeah, perfect. Yeah,
Good.
because I find it so hard. Like you'll see how much variation there is in the cardiac
Yes,
cycle.
that's true. Yeah.
You can
Yeah, that's a really good point, actually. Yeah, always valves closed. And I always freeze, obviously, to make your measurement, but I scroll back and then I scroll forward so that I can see in the right order, kind of, okay, now it's just closed. That's good.
Yeah. Yeah.
And realistically, this is like quite a luxury because this is all designed for people with heart rates of 80. And often they're closing like this. Like we get one frame with them closed, and it's like to do it just after they close is unrealistic. Just do it when they're closed. Okay. So for ECGs, does anybody have any specific things that they're interested in? Make sure we cover what you want to hear. Everybody really wants to go through the physiology, right? Everybody's favorite. So I'm not going to go into a lot of detail with this, but I do actually find it quite helpful to picture where the conduction pathways are in the heart when I'm comprehending what's happening on an ECG. So if we look at this image over on the right-hand side of the screen, what is this point here?
Sinoatrial node.
Great. So sinoatrial node triggers a depolarization that goes through conduction pathways through the whole right atrium, and then it goes through a little channel into the left atrium. So it spreads across from right to left in the heart. And if we're looking at our leads, that's going to read on lead 1, right to left, right, as a positive. So what will that correlate with on our ECG? What wave is that?
P wave.
P wave?
P wave, exactly. Atrial contraction. Now to tie this discussion in with our echoes, has anybody heard of the waves of ventricular filling? So how blood flows from the left atrium into the left ventricle and right as well, but so there's kind of 2 phases of ventricular filling. So if we're looking at a heart contracting in our 4-chamber view, what happens if we had it in really slow-mo is that systole would finish, our aortic valve would slam shut, but our mitral valve is still closed. Our ventricle is fully contracted and as empty as it gets. And then the ventricle is going to start relaxing. So this is called isovolumetric relaxation time. So ventricle's relaxing, but all the valves are still closed. So isovolumetric, no change in volume. Then you're going to get a vacuum in there, aren't you? If it's dilating without any change in volume and the valve's still closed. So that's going to suck the mitral valve open and suck the blood from the atria into the ventricle. So 90% of ventricular filling is not actually atrial contraction. The ventricle is nearly full by the time we're seeing our P wave happen. So after that initial filling, then the sinoatrial node triggers the atrial contraction. And that then causes the last little bit of blood to squeeze out of the atrium into the ventricle. And then the rest of the contraction to happen.
Is that what some people call the atrial kick or something?
Yes, it's
Or is that different?
Yeah, it probably is.
I'm sure.
I haven't heard atrial kick, but definitely like atrial contraction A wave. So we measure E and A waves on our echoes. And that's the flow into the ventricle. The E wave is the early filling, which is passive. And then the A wave is the atrial contraction. So that's sort of the link between the echo and ECG. If you've got an ECG running along the bottom of your echo, it's really nice to kind of visualize like, oh, I can see that. I can see that flow that resulted from the atrial contraction. So you get your P wave, and that's the very last part of blood flowing from the atrium to the ventricle. And then we get the majority of conduction going down these Purkinje fibers down the center of the septum. If we're looking at which lead is going to be most positive with conduction in that axis, where is that going to read the biggest?
On lead 2.
Lead 2, exactly. So lead 2 is going almost directly on the axis of that interventricular septum, that conduction pathway. So that's going to read positive, so above the line on your ECG. And then we're going to get distribution of the conduction up the heart, but almost in both directions. So that's going to be going away from the lead 2. So if we're only looking at our lead 2 trace, it's going to go below the line, isn't it? Because it's going negative. Does that make sense? Cool. So it's nice kind of visual to get, this is the initial direction, and then this is the kind of rest of the momentum, and then repolarization, which is the T wave. Okay, so let's do a couple of cases really quickly. Sorry, I always get too excited. Okay, this is a 5-year-old dog, had a heart rate of 90. ECG was run just cause. Tell me about this ECG. What do you screen for when you're looking at an ECG?
Rate and rhythm to start with.
Right. So I've calculated the rate for you because it's too annoying to do the counting, and we just want to move through these cases. So heart rate is 90.
So you look at rhythm next. And
yeah. How do you judge rhythm?
There a P wave for every QRS.
Good. Is there?
Yes.
Yes. Agree. What else do you look at with rhythm?
the space between the QRS complexes.
Good. The RR interval. Very hard for Brazilians to say, apparently. And the name Rory, also very hard.
That long RR interval is just over twice, I think, the normal RR interval. Therefore, it's a sinoatrial arrest or pause.
Mm-hmm. I think we might have just snuck into under twice when you do the calculation. Tell me about, so the RR interval is regularly irregular. If this trace was longer, you have speeding up, slowing down, speeding up, slowing down, speeding up, slowing down. So regularly irregular.
So it's, so it's probably a sinus arrhythmia. Is that?
Exactly right. So the other hint on this trace that there's a sinus arrhythmia here, the P wave morphology is a little bit variable.
Oh, okay.
So see this little one here? Yeah. So it's called a wandering pacemaker, and it's a marker of increased sinus tone. So typically when you've got variation, if you've got wandering pacemaker, they're usually that quite relaxed. Or have increased sinus tone, vagal tone for other reasons, like what other reasons cause increased vagal tone? What about a cat that's come in with laryngeal paralysis from a tick? Have you noticed their heart rates? Does everyone see ticks?
No, we don't see ticks. I'm in Holland. No ticks.
Ah, their heart rates are sometimes really low.
Oh, weird.
Yeah, so respiratory disease or respiratory obstruction will often cause increased vagal tone. which causes sinus arrhythmia and lower heart rates. Respiratory disease, ophthalmic disease, neurologic disease, and gastrointestinal disease can all cause increased vagal tone and wandering pacemaker and sinus arrhythmia. Okay, now it gets harder. So this is another, almost looks like a regularly irregular trace, right? Like we've got a slower stretch, and then we've got a faster stretch, and then we've got a slower stretch. The difference here is that the heart rate in the slower stretches is 150, in the faster stretches is 300. What do we think about this trace?
There's probably no P waves there because it's hard to tell.
I agree.
The T wave is that, no, I think we're seeing the T wave and no P wave, so that'll be an atrial fibrillation probably.
So through this stretch, what do you think about P waves?
Or are those P waves with no QRS after them? I find this confusing.
Here,
In the slower section,
the slower section.
yeah, there's like is it a P wave with no QRS or is it?
Oh, or is it T?
Yeah,
This one? I think this
Yeah.
is T.
you do that, okay.
Yeah, it's a very spiky T. It's a bit of a weird one.
Is the P spike like spikier as well?
Yeah, so I think that they've got their like magnitude turned up. So it's just, oh God, so sensitive. Sorry. So I think the P, this section looks like a sinus tachycardia to me. So 150 is probably a tachycardia, I would say.
Mhm.
So we've got P waves for every QRS. So there's spiky P, QRS T, spiky P to QRS T, P, QRS T, P, QRS T, P, I think QRS could be summated T and P. Like I can't say there's no P wave, but because the T waves now look a bit variable, don't you reckon? Like that looks like it's got sort of two complexes next door to each other. This one looks higher than the T waves over here. And over here, you can start to see them separating out again.
Oh, okay.
So there could be P waves, but I can't really see them. I couldn't make a call on it. What do you think about the morphology of the QRSs through that fast stretch?
They're very narrow.
Tall and narrow.
They're just on the top of normal as far as height's concerned.
Good. But are they, are we going to say the conduction pathways that we talked about? Do we think that this went down through the Purkinje fibers, through the bundle of His, and then up the walls of the ventricle? As far as kind of, we're on lead 2, all of the traces I'm going to show you are lead 2. So we're definitely positive. It's definitely gone down that normal pathway. It's not like the impulse started on the right ventricle, for example. So when you've got QRSs that remain normal and narrow, you know that the conduction pathways were followed. So we then know that the kind of impulse for that contraction came from the AV node or higher. So if you've got a nice narrow QRS that's positive on lead 2, you can say AV node or higher. And it could still be ventricular, like a VPC kind of thing, but it would have to be a junctional complex. So VPC that arose right at that AV node. In this case, I reckon we can see enough P waves to say that actually I think the contraction started higher than the AV node, because I still think there's some atrial contraction going on here. So I reckon the P's and the T's are probably overlying each other. So if we had to put some differentials out there, what do you reckon? What tachyarrhythmias do we see that arise above the AV node? Supraventricular.
Atrial fibrillation is one of them.
One of them, yeah. So it's a arrhythmia that arises from the atria, but it's more chaotic. So these
And then
far
You
into-
wouldn't suspect you wouldn't have P waves at all, right?
Yes, exactly. Yeah, so you could have atrial fibrillation that comes and goes. So you might have a normal sinus rhythm, and then you'll have a run of very irregular, no P waves, and then you might have normal sinus rhythm. But I do think I can see some P waves in here. And the other thing that's making me think probably not AF, it's actually very regular, isn't it? So when you listen to an AF, the classic is sand shoes in a dryer. It's a very chaotic rhythm. The RR intervals are very variable. And when it's this fast, it's very hard to measure that irregularity. But if we look here, the intervals here are very regular. So
irregular.
the irregular, exactly. Yeah. For atrial fibrillation. What's another atrial tachyarrhythmia?
If you get an irritable focus in the atrium that keeps firing.
Yeah. Or a re-entry circuit. So there's a few different mechanisms, but the name of that is SVT. You heard of that? Supraventricular tachycardia. And there's a lot of different ways that arises. So humans get a lot of different forms of that, and we recognize that in a lot of dogs as well. But the real key to sort of saying, okay, I think this is a supraventricular tachycardia, is the very regular lead up, the complete switch into a tachyarrhythmia that is like, it was normal, and then it was very fast, and then it was back to normal, is the key to making a diagnosis of it's not a sinus tachycardia. It's much too fast, and it's much too, like, it doesn't ramp up to that. It just turns on and turns off. Does that make sense? We actually better run. Sorry, I've gone over time. That was really fun. Thanks for playing. I can't remember what it is next week. Does anyone know? No. Helen.
Anna, there's an arrhythmia that's seen with tick paralysis, and I can't remember the name of it, where I think the T wave starts to impose on the P wave.
Can't think of it. I don't see any ticks anymore.
I just can't remember the name of it.
No.
I think it's a French term. Oh, torsade de pointe.
Oh, so that's common in magnesium deficiency, which is associated with critical illness. And that's a ventricular arrhythmia, a ventricular tachyarrhythmia. Interesting one. And it's called torsade de pointe because it's torsade is twisting around and pointe is twisting around the point. And it's like the ECG looks like this. It's really interesting. Yeah. Have a look at that in your own time. See ya.
Thanks, Anna.
Thanks, Anna.
No worries.
Bye. Thank you.
Bye.
Thank you.